the broad anticoagulant, antiplatelet considerations, and now we'll focus really specifically on ECMO and some of the unique consideration that the ECMO provides. And it's a bit of a complex situation as we'll learn together and work through some cases towards the end. At any point, please, just like before, we want this to be interactive, so please stop, ask questions, clarify at any time. My disclosures are here. I provide consulting for UpToDate and Lexicomp, and none of these are related to what we're talking today. So like I mentioned, we'll talk about strategies for maintaining anticoagulation on ECMO. And this is really the depth of what we'll focus on today. And so I heard one of the questions asked in the first session was if anybody sees ECMO or handles patients with ECMO. I think I saw one or two hands come up. I see some more head nods now. So do you want to take a moment to talk about what ECMO is, because this is very important to the question of anticoagulation. And so here we have two of the most common forms of ECMO, but broadly speaking, ECMO is a mechanical life support system that offers respiratory and or cardiac support through extracorporeal circulation. So in general, venous blood is drained from a great vein. It is passed through an artificial lung where gas exchange occurs, and then that blood is delivered back into the venous system or the arterial system, depending on the type of ECMO that is provided. So veno-venous ECMO would be here on the left, where we're drawing blood from a great vein and then returning it back into the right heart. And then veno-arterial ECMO on the right side, again drawing blood from a great vein and returning it into an artery for cardiac support. This is the formal definition. I think sometimes we take for granted the basics, and this can get lost. But this is very important when we talk about coagulation and coagulation disturbance and hemostasis. And so this is the formal definition that the Extracorporeal Life Support Organization says what ECMO is. They say ECMO is defined as the use of modified cardiopulmonary bypass for temporary life support for patients with potentially reversible cardiac and or respiratory failure. They go on to say that ECMO provides a mechanism for gas exchange as well as cardiac support, allowing for recovery from the existing disease. And so I highlighted some terms here because I think these terms here are the most important to the coagulation discussion. The first is that ECMO is a temporary life support. It certainly can go on for some time, but it is not a permanent support. And also, it is meant to provide a bridge for a recovery or to a more permanent situation. And so the question you might have is, well, what does actually temporary mean? And I think when you ask somebody differently, you will hear something else. So I want to get a feeling from the room of what you think temporary is. Is it seconds, hours, days, weeks?
Probably months.
Months? Days? Days, okay. 2 weeks, okay. Yeah, so there's lots of variation here. And I think when we look into literature, we can see that this definition of temporary, we might be a little surprised by what we find. These are just a collection of some papers that I was able to find of prolonged ECMO support. And you can see here, yes, maybe 2 weeks, maybe days, but also it's possible to provide ECMO for hundreds, 200, 300 days. And so this is really important when and we'll talk about why this is critical,
I
yes.
have a question. For example, 100 something days, the patient is sedated or awake?
It depends, yeah, mostly awake, yes. Usually, the primary goal of providing ECMO support is again to provide recovery. And so the intent is to awake them, liberate all the sedation, have them participate. This is a very good drug support, yeah. Especially if the goal is for a transplant or something, then they should be able to do those activities.
What is the difference between the ventilator and ECMO machine?
Very good. Yeah, great question. If we provide ECMO for respiratory support, it is because we have exceeded the capacity of ventilator. And so this is a indication for ECMO is a refractory respiratory failure. And so although we can provide satisfactory gas exchange with a ventilator, if someone has a refractory disease, we might have to push the ventilator settings to where it starts to provide some injury. And so ECMO provides a way where you can provide gas exchange, but minimize the injury from the ventilator. But in concept, it's essentially doing the same function. So the ECMO can provide oxygenation and decarboxylation. And so this concept of temporary support is something that is changing over time. You can see here, this is a letter from a few years ago, and you can see 25 years ago they say it was common practice to withdraw support from respiratory ECMO if there was no evidence of recovery after 2 weeks. And they go on to say this was a communication with Dr. Bartlett, that he had a satisfactory outcome on a patient supported on ECMO until transplant for 600 days. And so if we look at the data over time, these are the past 30 years in the extracorporeal life support registry. You can see back in the 90s and early 2000s, the average ECMO runs were 1 to 2 weeks. And now in 2009, when we have the influenza H1N1, we start to see the increase in the amount of ECMO we're doing and the duration of support. This is largely, we've been learning how we can support patients for longer, manage the complication, and those types of things. But this is very important about temporary because when we look at the coagulation situation, the hemostatic disturbance, we find that thrombosis on ECMO is very common. These are data from a group in Germany where they compared the thrombosis before death and then on the autopsy finding. And you can see the thrombosis before death is in the white bars, and then the autopsy finding is in the gray bars. And you can see that the thrombosis is happening very often, but we're not finding it clinically. And so this is suggesting that on ECMO, there is some additional hemostatic disturbance that increases the risk of thrombosis. And when you provide ECMO support for longer, this risk of thrombosis continues to go up. And so this is VA ECMO support. You can see here in this data set of about 80 patients, when they followed them for 10 days, the risk of thrombosis was almost 100% over the course of 10 days. If we look at the data in a global scale, on the left here is the data from the ELSO International Registry, and I highlighted in the red boxes here the complications that are related to coagulation disturbance. And so although ECMO is very intensive, it's very invasive intervention, and there's lots of complications that can happen, you can see that bleeding and thrombosis are some of the most common that we experience during ECMO. And also these complications, they reduce the chances of good outcome. So you can see on the right, patients who have bleeding events on ECMO are less likely to survive. Also, what we obviously want to avoid is catastrophic events. This is left ventricular, very, very large left ventricular thrombus in a patient supported on ECMO, and this is almost always catastrophic outcome, not survival. And we'll talk about some of the situation of why this might occur on certain types of ECMO supports. So during ECMO, there's many things that contribute to this coagulation disturbance. First, we have the oxygenator, we have tubing. I know there's many people here that have deal with ECMO. These are very large cannulas, very large tubing. The amount of surface area that blood is exposed to is very high. And so these are non-biologic surfaces, they're non-endothelialized surfaces, and so they activate cytokine pathways, they activate coagulation, intrinsic coagulation pathways. There's also connections at many different points. I'll show you some pictures of these in a little bit. There's a pump, and so again, it's lots of foreign surface that contributes to coagulation disturbance. There's also mechanical shear forces from pump. This is a artificial environment, and so can damage blood that passes through it. The access that we use is very large bore access, probably outside of providing cardiopulmonary bypass in the operating room, the largest bore access that we'll provide in critically ill patients. And also, these patients are critically ill. They have a refractory disease, and so they oftentimes have other conditions. They have sepsis, infection, other acute illness that also contribute to the coagulation disturbance. These patients may have a platelet and a factor consumption, excess fibrinolysis, and of course, coagulation, a dilutional coagulopathy, especially early on when they go on ECMO, they may receive a lot of resuscitation, a lot of crystalloid resuscitation, have a dilutional coagulopathy. And also, like we just talked about before, intraventricular blood stasis is a problem if we're providing VA ECMO for cardiac support and the patient has very severely impaired heart function. The blood can pool in the cardiac chambers, and this can be catastrophic if thrombosis occurs.
Any comparison between the hemodialysis machine?
Very good question. So the question was if there's comparison between this and hemodialysis. And so hemodialysis is far less risky. So hemodialysis is usually provided through a veno-venous access, and you really just need a central line. And so it's a very small central line. Hemodialysis, usually blood flow rate around 200 to 300 milliliter per minute. ECMO is around 4 to 5 liters per minute. And so the tubing is very large. You also require mechanical pump, whereas hemodialysis is usually molar pump because it's a much smaller blood flow rate. And so and also the hemodialysis just passes through filters. There's no artificial membranes outside of the filters, and so it's much less risky from that standpoint. So I put together this slide because I think many people can relate when we talk about the Virchow triad of the coagulation, the three pillars of coagulation. And I think there is a nice parallel for ECMO. And I like to call this the ECMO triad. And so these are the three pillars that are you can see around the triangle is what you think about for the Virchow triad, and then I added on the outside of what is specific to ECMO that is unique. And so the Virchow triad, one of the pillars, the abnormal endothelial surfaces, and in ECMO, of course, we have artificial surfaces which can provide a procoagulant effect. It's a pseudoendothelium which affects the fibrinogen. Again, it's a non-endothelialized surface. And also there's a disrupted endothelium, right? To place ECMO, we can do this percutaneous, which is less invasive, or it can be done through a cut-down surgical approach, which is more invasive. But either way, there's surgical sites, there's cannulation sites, and these are disrupting native endothelium. The hypercoagulability of Virchow triad in ECMO, there's lots of tissue factor release. There's hemolysis, because again, we have these surfaces where blood is passing, and we'll talk a little bit more about hemolysis and free hemoglobin. There's acute illness that can contribute to this. Patients, again, they have sepsis, they have other things going on, so they can have disturbances in their factor VIII and their other coagulation systems. And then also the deranged blood flow. Unique to ECMO is, I think these are very, and it's quite different than hemodialysis, in that ECMO, there's places where we can have turbulent blood flow. And so turbulent blood flow is where the flow is not laminar. And so there's something that is disrupting laminar flow. And usually in ECMO, this is places where we have connectors. So we may have a Y-site connector where we're bridging two lines together, or really anywhere that we have a connector that introduces a defect in the laminar flow. And when you have turbulence, you increase the risk of thrombosis. This can happen again in the tubing, in the pump, in the oxygenator. We talked about the large surfaces and the shear stress that the pump can provide, and also low flow. There's areas, perhaps in the circuit, where we talk about the flow. It is around 4 to 5 liters per minute, but there's some areas, depending on the configuration, that this could be very, very low. The centrifugal pumps are not benign. These are pumps that provide continuous flow, and one of the most obvious complications is a acquired von Willebrand deficiency. And so this is a very nice study where they measured the von Willebrand factor, different molecular weight bands before ECMO, 24 hours in ECMO, 48 hours in ECMO, and then after ECMO. And you can see that when you are exposed to ECMO, you lose high molecular weight von Willebrand bands. And this is completely reversible when you remove ECMO. And so this is a direct effect related to the centrifugal pumps. And so like we talked about, ECMO provides unique considerations for coagulation management. This is a picture I took a little while ago. This is a oxygenator. So the membrane that provides the gas exchange during ECMO, they just sliced it in half, but this is what it looks like on the inside. And what you see here is two different chambers. One chamber has just the oxygenator fibers, and so these are very, very small fibers where gas passes through. And then as the blood passes across the fibers, the gas exchange occurs across the fibers. But you can see how densely packed these fibers are in these devices. And so I'll provide some more pictures actually in the next slide here But as blood passes through this, it's so densely packed, and you can imagine that if there's some deposits or something, it impairs how the blood flow passes across those structures. And then also, ECMO has many connectors. So the picture over here on this side is, this is a connector. You can almost see here, this is coming off of the oxygenator, so off of the membrane. And what I've highlighted here, hopefully you can see it, this is some fibrin. So fibrin that started to grow off of this connector. And this is can be very problematic for specific types of ECMO support where it can be very risky. So this picture I took on the right-hand side, a patient on VA ECMO, cardiac ECMO. And so this line that is returning oxygenated blood to the patient is directly into an artery. And so if that fibrin embolizes off, it goes straight to the brain, spleen, kidneys, and has a very big consequence.
Excuse me, how about hypovolemic shock can be as a high risk for the situation by using the ECMO?
Oh yes, absolutely. Yes, should be stable. Yeah, absolutely. Yeah, it's not treating hypovolemic or hemorrhagic shock, but it can happen on ECMO, and then we treat it. But we wouldn't put somebody on ECMO because of it. You can see here, this is from a pediatric case we had. The pediatric ECMO can be very complicated. We do some ECMO for congenital disease, and so the circuit configuration is even more complex. And you can see all the different connectors, and this is, all of these spots are very prime location for fibrin deposition and thrombus growth. Here you can see this is the oxygenator faceplate. And you can see thrombus and fibrin straining here that develops. This is most of the time actually normal and expected. This will happen during ECMO support. It's just a matter of how bad it gets and what the configuration and consequence can be. This is, you can see just better the thrombus. This is an oxygenator after we washed it with crystalloid. So you can see all the blood is washed out, and you can see the thrombus that remain. And so there's a patient ECMO interaction between the goals. So on one hand, you have the patient, which the goal is always the adequate hemostasis, minimizing transfusion. We learned in the previous session how transfusion has risks, and so if we can avoid the transfusion, that would be ideal. And then there's also the ECMO circuit goals. We have to consider ECMO as a precious resource, and we have to take care of it, because if we don't take care of it, it can be unsafe for the patient support. And so goals here are usually to minimize the platelet activation and minimize the fibrin deposition that occurs in the circuit. And so the ECMO provides a unique challenge. So on one hand, we want to preserve the function of the membrane. So this is, again, a membrane that is no longer being used for support if it's been washed with saline. But you can see all the clot that's in there. And this is not good, because the more clot you deposit into the membrane, the less efficient those fibers are at exchanging gas. And so we want to prevent this, but also we don't want to have catastrophic intracranial events. And so the question is, why do we provide anticoagulation on ECMO? Hopefully you're gathering this by now, is that you have lots of contact phase activation, which generates thrombin, and blood interaction with ECMO just compounds this situation and makes it even worse than than in normal critical care. There is also, like we've talked about, device-induced thrombosis. So we have device surfaces that promote all of these coagulation disturbances, activation of various factors, platelets, complement systems, which just cycle on themselves to make it a very prothrombotic situation. Here you can see pictures of the pumps, what they look like if there's a thrombus that forms in the pump. And then also some images of oxygenator to see that there is lots of thrombus that always forms in these oxygenator. So we previously reviewed the coagulation cascade. I would agree that no talk would be complete without having the coagulation cascade, so I'll remind you all of this again, but we won't go through the specifics. I do want to highlight one very important thing from this as it pertains to ECMO, and that is the central role that thrombin plays in all of the coagulation situation. And you can see that thrombin activates factors 5, 11, and 13, and this is really central to formation of fibrin and ultimate stabilization of clot. And I'll share a little bit more about why this is so critical in ECMO support. And so this is a timeline of how thrombin propagates. So when tissue factor is activated and thrombin begins to initiate, you can see the initiation phase is just a couple of minutes, and then within a couple of minutes, the propagation of thrombin is exponential. You can see within 10 to 15 minutes, you have almost 10,000-fold increase in thrombin concentration. And this is the exact reason why, if, for example, you cut your finger on something small, that you don't just bleed to death. It's because you rapidly propagate thrombin, and this stops catastrophic bleeding from just a minor injury. But on the other hand, this is very important in ECMO because we talked about all of these different procoagulant issues in ECMO, and so they're all propagating thrombin activation. And that's something that we want to temper when we manage the patients. This is just showing how important thrombin is in ECMO and how much more thrombin concentrations are increased in ECMO than in normal critical illness. And so there's been a lot of interest in anticoagulation in ECMO over the years. And so what I've shown you here is the number of papers that are published of ECMO anticoagulation over time. And so in the black bars is the total number of ECMO centers in the world. This is a cumulative number. And then in the blue line is the number of new papers every single year that are published about ECMO anticoagulation. You can see, as we had the H1N1 influenza 2009, MERS 2015, and then of course the COVID-19 in 2020, the number of centers that provide ECMO support is dramatically increasing. But also during this time, you can see the exponential interest in ECMO anticoagulation, and I'll talk a little bit more why this is, why we're seeing this. And so this should probably be no surprise, but when we talk about what an ideal ECMO anticoagulant is, it should probably have these three things. It should be something that is effective. It prevents thrombosis. It should be reversible if we need to counteract the effects. And also it should be titratable where we can achieve a desired effect. And so what do people do about this? maybe I'll ask the group before I go to the next slide here is, for those that have ECMO in their center or if you work with ECMO, how are you providing anticoagulation? Heparin. Anything else?
Bivalent sometimes.
Bivalent sometimes, okay. Yeah. So when you ask ECMO centers worldwide, you'll see that, of course, most centers, 97% are providing anticoagulation. There's some situations when you might not, but that's beyond what we'll talk about today. And then of these, you can see that 97% are heparin. Almost everyone is using heparin. And I think this goes back to our conversation about the interest in anticoagulation. And you may think, well, you know, we have like a standard of care, why is there so many new papers in ECMO? And I'll hopefully answer that here shortly. So some of the reasons we use heparin, I think this is all things that we're very familiar with. Heparin is very familiar. We all know how to use it. We all know about it. We've used it in the cardiac operating room for bypass for many decades. It has a pretty good pharmacology. It has a quick onset. It has a relatively short half-life, and we talked about protamine as an antidote in the previous session. It's readily available and it's pretty cheap. But I will ask the group here, does it satisfy the criteria of an ideal ECMO anticoagulant? I think reversibility, there's no debate here. There's an antidote. But what about the other things? Do we all think that it's effective? Do we all think that it has titratability? Yeah? Yes? Okay. Is anyone skeptical?
Dependent. I feel like it depends.
Depends? Yeah, okay.
The issue would be if patient has it, so
Mm,
we
okay.
use the alternative.
Okay.
Other than that, allergies or something else, or actively feeding patients, it would be the issue.
Okay.
But other effectiveness, I don't think so.
Okay.
I don't have really experience with it, but
Sure.
this is what I'm thinking.
Yeah, very good, very good. Okay, so maybe some situation where we may need to reconsider. So heparin has some issue that I would like to highlight that I think is pertinent to the ECMO discussion. This is a study of dosing, heparin dosing in patients receiving cardiac surgery. And so in this study, they sought to identify characteristics that are associated with different dosing requirements in patients who receive cardiac surgery. And you can see the different colors are the different surgical procedures they had. But these authors, you can see that even when they grouped the types of surgeries they had, there's still quite a bit of variability within those patients. And these authors, they built models, and they found that 70% of the variability in heparin dosing was not due to factors that were readily available to the clinician. So things that you would normally expect, someone's sex, age, liver function, all the things that you would have at the bedside, 70% of the variation in the dosing could not be explained by those things. And so heparin, I think if anyone manages continuous heparin infusion, I think you can all attest to, you check the APDT every 6 hours, and it seems like you're constantly changing. It's very rare that you have a very stable heparin dosing requirement. And so because of this, there's a very wide dosing range. Heparin, of course, requires antithrombin for its anticoagulant effect, so you're consuming antithrombin. You can have an alteration in the clearance mechanism, particularly with ECMO, with patients, again, who are critically ill. They have liver dysfunction, and this can affect how they respond to heparin. Heparin decreases the platelet count, It also interacts with many, many plasma proteins, and this might be the reason for the variability in the dosing. It interacts with all of these different proteins, and all of this leads to a constant need for dosing adjustment. These are laboratory data. Porcine and bovine-derived heparin products are the most common in the world. And you can see at the manufacturer level, these are samples from vials straight from the factory. They measured APDT activity, anti-10A activity, and you can see the range of this. These are vials that came straight from the factory. They don't provide a consistent anticoagulant effect. And this doesn't even consider the patient factors. This is one of, I think, the most compelling arguments against heparin during ECMO is its interaction with thrombin. So heparin, as we all learn, heparin does not treat clots. It only prevents the clot from growing. This is because it only interacts with circulating thrombin. It does not have any effect on clot-bound thrombin. And so we provide heparin to prevent propagation, but not to actually treat the clot. And again, we talked about ECMO has all of these connectors. It has oxygenator, pump, all of these places where thrombus can develop and grow, where heparin isn't affecting those parts. So we talked about the dose-response relationship. It has platelet factor 4 vulnerability, so potential immunogenic reaction, relies on antithrombin, and also the issue of heparin resistance. And so a question comes up about antithrombin. Are we all checking antithrombin? Is everyone here checking antithrombin levels? No? No?
Where?
When you ask other centers, you can see here that this is a study from Italy where they surveyed all ECMO centers in Italy, and you can see that they monitor this is during ECMO, they monitor the antithrombin level usually every day. This is a lot of monitoring, right? But what does this tell us? We know that antithrombin deficiency is very common during ECMO. Here, this is a nice study over 7 days on ECMO. You can see, especially in the early periods of ECMO support, antithrombin deficiency is common. But this study found that antithrombin levels were not associated with heparin responsiveness. And so the question is, does treating antithrombin levels, is it just treating a number? And this is something that is being more and more discussed lately. This was a randomized trial from Italy where they had ECMO patients, and you can see that the antithrombin levels so they randomized patients to receive antithrombin or not that were on ECMO. And you can see that giving antithrombin increases the antithrombin concentrations, but the heparin doses were basically the same. Their APTT was even closer to being the same. And so heparin has all of these considerations that makes ECMO's already complex and confusing, and this kind of just adds to that situation. And so there's been a lot of interest lately in direct thrombin inhibitors for ECMO. We learned before about the characteristics of bivalirudin and ergatroban. I just wanted to show them side by side here because in the story of ECMO, they're not necessarily the same. And we'll talk a little bit more about bivalirudin specifically because it seems to have a more favorable pharmacology profile. You can see it has a very short half-life, does not interact with any plasma proteins. It is very specific to thrombin. It is, of course, a direct thrombin inhibitor. although there's not an antidote, the binding to thrombin is reversible. And then also, its clearance is not really dependent on organ function, it's cleared by the plasma. So bivalirudin is synthetic. This is different than heparin. Heparin is a animal-derived product, and so this is a actual small molecule that is synthetically produced. Does not require cofactor for its effect, and then also has organ-independent metabolism and no effect on platelet factor 4. So there's no issue of thrombocytopenia with it. We actually use it quite often when patients are thrombocytopenic and we need to provide anticoagulation, and it does not have a immunogenic reaction. I've heard that, maybe if a patient has HIT, we might consider using this. One of the most compelling reasons for using bivalirudin during ECMO is the interaction with thrombin. So we talked about heparin. Heparin only affects the circulating thrombin, which bivalirudin also affects the circulating thrombin. But a benefit to direct thrombin inhibitors is that they engage with thrombin that is already bound to clot. And so not only does it affect circulating thrombin, it affects clot-bound thrombin. And so this is particularly attractive in ECMO, right? Because we have all of those connections in ECMO. We have the oxygenator, so many spots where we can have fibrin deposition and thrombus deposition that is essentially inevitable during ECMO support. Some of the early experience with bivalirudin, you can see the dates on these papers. This is 2007, 2009, so very, very young. Only about 15 years ago were the first papers published of using this during ECMO support. And like was mentioned, this was for patients with HIT. These are just a couple case reports where they reported successful ECMO support for patients with HIT. A group in Italy was the first ones to provide a systematic evaluation of this. This was a small sample, you can see here, just about 20 patients who received ECMO after cardiac surgery. And the patients who received the bivalirudin in their sample had less bleeding, and they required less transfusions than heparin. These are data from our center over the course of a few years. You can see a much larger sample here, about 300 patients. Bivalirudin had less circuit thrombosis and also some less transfusion in pediatric patients. Another study with respiratory ECMO showed that bivalirudin, again, this is about 300 patients. These patients had less bleeding and less circuit thrombosis, and then required less transfusion. Similarly, in medical cardiogenic shock, this was the same group as the previous slide. They found similar findings for bivalirudin in VA ECMO. And then just to belabor the point, this is another smaller study. You can see only 13 patients with bivalirudin, mainly for HIT, but these patients required less transfusions. And so our group, we did meta-analysis, and we found that bivalirudin has less circuit thrombosis, but not systemic thrombosis. And so this lends to the pharmacology, right? We talked about the differences with heparin and that the interaction with thrombin, and so we would expect it to it's still showing here.
I don't know, can I skate?
I'll just keep talking here. So when you pull the evidence from the studies, you see that the circuit thrombosis is less, and the bleeding is similar to heparin. We showed some studies where maybe the transfusion requirement is less for bivalirudin, but our evaluation found similar major bleeding, and there was we found a better mortality with bivalirudin, but this has very big selection bias because, like we talked about, the bivalirudin used with ECMO is very young, and so the data represent largely newer studies, and so as we learn more about managing ECMO, the survival outcome, regardless of anticoagulation, is better, and so that's not, I think that it is a finding that requires caution. But I want to gauge the room of why you think we're seeing the bleeding outcomes and the transfusion outcomes favoring bivalirudin. Usually people think, well, there's no antidote for bivalirudin, we can't reverse the effects. I'm concerned about using it because of this. That's the most common thing I hear. But the data suggests otherwise. So I'm wondering if anyone has any thoughts about why we're seeing this.
We're used to heparin and it's cheaper.
Yeah, you said
I think people are not comfortable using Bival.
Yeah, I hear this all the time, and from our own experience, and I'll share a little bit about what we're doing at Mayo. We have found that even though there's no antidote, that you can't reverse it, the half-life is much shorter than heparin, and also the thrombin binding is reversible. And so even in our surgical cases, we use it, and we find that just stopping it, the drug effect is washed out way faster than heparin. And also, this is beyond the talk today, but we talked in the previous session about reversing anticoagulation. Usually in ECMO, we avoid that because it could produce a catastrophic thrombosis. And so I think that these are some of the reasons why we're seeing some favorable effect on transfusion and bleeding. An interesting finding is that bivalirudin provides a much more stable dosing requirement than heparin. These are several studies that compared heparin to bivalirudin, and this was the percentage of time that patients spent in the therapeutic APTT range. And you can see in all the studies, there was much more time spent in a therapeutic range with bivalirudin. The dosing requirement is much more stable. A question that gets asked is, well, when you combine dialysis with ECMO, how does this affect the bivalirudin? Usually it doesn't affect it a whole lot. Maybe over time you have some increasing in the requirement, but overall you can still manage, and you find that the dose and the APTT are pretty similar. For those of you that have ECMO in your centers, do your centers have protocols for managing the anticoagulation?
I think in the ICU setting they have a protocol,
Okay.
not hospital-wide.
No hospital, yeah. Okay.
So almost they need it in the ward, they take the protocol from the ICU.
Yeah.
For me, I don't know because I'm a physical therapist.
Oh,
I'm
okay.
dealing with the patients.
No problem. Protocols have found to improve care during ECMO, and so if you don't have a protocol for ECMO, introducing one can be very beneficial. This is a protocol specifically for bivalirudin from a different center in the US, And they found that after introducing the protocol, they had much more therapeutic APTT, and they had less sub and super therapeutic APTT. And this was even after they're providing less titrations. So standardizing the care is very helpful. One phenomenon that we've observed pretty recently as we started to use bivalirudin more is this type of phenomenon that looks like a heparin resistance. So the heparin resistance where you don't have antithrombin, so you keep increasing the heparin dose, but you're not achieving a therapeutic APTT. We have actually found something similar with bivalirudin. In this analysis, you can see that up until about 0.2 milligram per kilogram per hour in dose, there's a pretty nice linear relationship with the APTT. But then after this, the incremental increase in APTT is dampened. And this seems to be an issue with acute phase reactants. We think it might be driven by factor VIII levels or fibrinogen, but it seems like their response to APTT goes away at higher doses. It doesn't necessarily mean that they're not anticoagulated. It just means that the APTT seems to be unreliable at a higher dose. We introduced some different monitoring techniques because of this phenomenon. I'm not sure if any centers use other anticoagulation monitoring like a thrombin time, dilute thrombin time, chromogenic assay. No, I know it's not very common. Yeah, we started doing a bivalirudin concentration because of the issue with the APTT. And so these are samples that we took from the same patient, and the colors represent individual patient. And so these are on ECMO bivalirudin, and you can see the APTT, the response, the dose to APTT response is pretty flat. So much so you can see maybe if you look at this one here, this yellow color, you can see that the dose, as the dose was increased, almost by 50%, the APTT was unchanged. But then when you look at the bivalirudin concentration, you can see that they're actually anticoagulated. It's just that the APTT is not reliable at higher doses, and this is something to be aware of. One thing to be very, very cautious about with the bivalirudin is its metabolism mechanism. And so bivalirudin is metabolized in the plasma by proteases. And so with a very short half-life, if you just put bivalirudin in a cup and you just let it sit there with blood, the blood will metabolize all the bivalirudin and you won't have any anticoagulant effect left. This is very different than heparin, right? We collect many different lab samples in heparinized tubes because it's stable, but you can't put bivalirudin in a tube and let it sit because the blood will metabolize it all. This was a case where they did a heart transplant on bypass that had HIT. They did it with bivalirudin because there was HIT. And this, for those of you that are not familiar, this is a venous reservoir from the cardiopulmonary bypass machine. It's usually filled with blood during the case. They can drain it into the bypass machine to provide more blood or less blood in the circulation. And you can see, this is a picture after the end of the procedure. They drained all the blood from the reservoir, and you can see the clot. Right, this is huge clot. And this is because the blood was just sitting in the reservoir and it was not moving for the duration of the case. You can see the ACT was very high during the case for 3 hours. And But stagnant blood flow is a big issue for bivalvular. I think I'll skip a few here. One of the most common things that I get asked about is, well, the data, it's very convincing, but you seem like you're very interested in this, but I think there's many situations where you should definitely avoid it. So one is the situation of minimal to no pulsatility. So this is patients who are on VA ECMO who have very impaired cardiac function, maybe their aortic valve is not even opening, and their LV is completely failed. This is problematic for bivalvular because the blood can just sit there in the ventricle and there's no passage of fresh blood to deliver bivalvular. And so this is a situation you should definitely avoid bivalvular. Low ECMO flow or turn down assessment. Our practice is not to do turn down assessment in the ICU. I know many centers may do turn down assessment in the ICU to assess the ability to come off ECMO. We do it most of the time in the operating room, but if you're doing it in the ICU, this is a situation too. Again, if you're decreasing the amount of flow, you should not use it. And then also the inability to assess APTT. APTT is the way to assess bivalvular, so if you can't do this accurately, then you should avoid it. I heard in the previous session that some centers are using anti-10A. Yeah?
Do we have flow for, a definition for the low ECMO flow? What
Not
is
really.
considered a low?
Yeah, it's kind of vague. My recommendation is always if we go below 1.5 liters per minute. Yeah. Usually if you're above 1.5, you can get by, but below this, you should be very, very concerned. So I heard some centers may use the anti-10A, and we do this if we can't assess the bivalvular APTT. Situations that we see with ECMO are patients with lupus. We sometimes get patients with lupus who have a very big PE and they require ECMO for either they have cardiac arrest from the PE or it's a very big PE and they have a right heart failure. And so in these situations, their APTT is very unreliable. And so there needs to be an alternative way to assess that. And so I think we may have, yeah, the alternative is to do the heparin with the anti-10A. Yeah.
Because they usually have a high APTT.
Exactly. Exactly. They have a high APTT, and so you can't assess how you're doing the anticoagulation. I know some centers are trying to use the TAG for this, but it's very challenging. So I think we have maybe a few minutes left. 10 minutes? Okay. And we'll talk through some cases. And so I left these without answer choices because I wanted them to be a little maybe more interactive, and I think there's always some different perspective that different people bring. So this is a case, so ECMO team is consulted for a 25-year-old man with refractory ventricular fibrillation arrest in the ED. He's placed on peripheral veno-arterial ECMO through the femoral vessels. In the ICU, the echocardiogram shows that the aortic valve is not opening and he has a severe mitral regurgitation. So he's listed for the cath lab to receive Impella to decompress the left ventricle. And so what are your approach to the antithrombotic plan? What are the things that you're thinking about with a case like this? Heparin? Okay. Is there any more information that you would maybe want to know? Mm-hmm. Yeah, very good. Yeah, I would agree. So the situation is this is a very severe cardiogenic shock. There's a cardiac arrest, very impaired left ventricle. Um, uh, Seeing a thrombus develop in the left ventricle is almost always catastrophic outcome. It doesn't happen too often during ECMO support because we decompress and we provide anticoagulation, but it's something that must be avoided. And so I agree heparin is the best choice here. Next is, so this is 48-year-old man with end-stage COPD and emphysema placed on ECMO, received a single dual lumen cannula in the left subclavian vein as bridge to lung transplantation. He has history of frequent nosebleeds, but has never been on any anticoagulant agents and has not had a conclusive hematologic workup. Discuss what your implications for considering anticoagulation during this patient's situation. Yeah, both, okay. Yeah, very good.
Yes, in between.
Yeah. So it could be either, both options. This is maybe a little bit of a trick question because some people may say, well, maybe you can just avoid it and not give them anything. And that I think is also not a wrong answer here. No, we didn't talk about no anticoagulation ECMO, but it is something that is getting a lot more interest lately, especially in a situation like this. Yeah. But there's no right or wrong answer. You could not give something. You could give heparin or bivalirudin.
And from this music thing, it could be local cause that the communication help in this issue and give options to start with.
Yeah, very good. Yeah, maybe some local treatment for the nosebleed. Yeah, very good. Okay, this one, it's a long one. This is a 61-year-old man received 3-vessel cabbage surgery. On the 3rd day after surgery, he has respiratory decompensation, found to have bacterial pneumonia, develops ARDS with refractory hypoxemia, and is put on ECMO. He's placed on heparin infusion for anticoagulation. He is having a satisfactory gas exchange with a very high ECMO flow of 5.7. He's awake and participating in physical therapy. The ECMO specialist comes to you and says there's a new mobile fibrin that is present on the ECMO outlet line. So this is the line that comes from the oxygenator. The heparin anti-10 assay has been consistently low, very low here. Discuss your next steps with anticoagulation management. Switching? Okay. So I hear switch to bivalirudin maybe? Okay. Yeah, I would agree. I think that's what I would tend to recommend. I think another answer could be to just hold it, to not provide anything. Almost 6 liters of ECMO flow in veno-venous is very high. Again, this isn't something that we talked about, but that could be a reason to not provide anything. But on the other hand, you have some mobile fibrin, and so you want to avoid the consequence of this. This patient is on veno-venous ECMO, and so embolization of the fibrin is maybe a little bit less consequential because it could be captured by the lungs rather than into the arterial system, and so the situation maybe has a little bit of a different risk benefit. Okay, this one, not a lot of information, but this is a 19-year-old man, has a witnessed PEA arrest in the hospital lobby, thought to be from hypoxic arrest from unknown drug ingestion, and is put on ECMO. The identity of the patient and their past medical history is not known. Discuss your approach to anticoagulation. This is a case that I had a few weeks ago.
But also anticoagulation versus heparin versus bilirubin, has lots of options.
Yeah, lots of options, yeah. Heparin, yeah, heparin, okay. Yeah, I would agree. Yeah, I would agree heparin. I think before, I would want to know some more information maybe. It's challenging in this situation, but if he has a witness arrest, he was likely in reasonable health, or at least a reasonable health to not have any prior catastrophic bleeding event. But with a cardiac arrest, you want to be concerned about a very impaired cardiac function. Okay, I think last one here is 41-year-old female with complex congenital heart disease. She underwent 5th time cardiac surgery. This time had mechanical aortic valve placement, mechanical mitral valve placement, and repair of tricuspid valve. After coming off a bypass machine, protamine was administered for reversal of heparin, and she had flash pulmonary edema and acute severe RV failure. She was put back on bypass and converted to central ECMO, and then the chest was packed open. She comes to your ICU, very coagulopathic, but no apparent surgical bleeding. What are your considerations for anticoagulation? Hold it, yeah. Okay, so I hear, yeah, monitor, yeah. Yeah, this is a challenge, very, very challenging case. One that I actually had a few months ago. Holding is something that makes the surgeons very nervous because this is a patient who has 2 mechanical valves. They're on VA ECMO, so VA ECMO diverts the cardiac output from the native cardiopulmonary system. And so central VA ECMO, you may be diverting 80% of the cardiac output, so you have a very small amount of blood flow through the heart. And so you have a small amount of blood flow that's passing across those valves, and that's very concerning, right? I think for me, I think holding is reasonable, but for not to, that's very risky, yes. Exactly, yes. Yeah, some might consider reconfiguration of the ECMO, maybe adding an additional reperfusion cannula to increase the amount of flow that goes across the valve, and then provide anticoagulation. This is a very, very challenging situation that can happen.
Stitches are.
Yeah. No. In ECMO, we avoid all oral anticoagulant. Yeah, the half-life is too long. Yeah. Even patients that we keep.
Issues with mechanical valve.
Yeah, exactly. Yeah, but this patient has, so their sternum is wide open. They still have the surgical cannulas. Yeah. That was it. Thank you so much. Happy to take any questions.
Thank you very much.
Yeah.
That know it's previous experience. I have patients absent in the hospital.
Oh, sure. Yeah, that's a common situation. Yes. Like they're on the filter or something. Yeah, we would stop the filter. Yeah, exactly. And then when we come back, we'll put that.